The article we're reviewing is for LLSA 2021 in Emergency Medicine. It's titled Bag Mask Ventilation During Tracheal Intubation of the Critically Ill Patients, also known as PREVENT, by Casey et al. And we're joined by Matt Delaney. You're going to be driving the bus on this article, so what you got?
So this is a neat little bus. This is one of these questions that I'd never really had, didn't think needed to be answered. These guys look at it, and it's an interesting answer. So the basic background here is the idea that hypoxemia occurs often when we're intubating patients. This study looks specifically at patients in the ICU, and they say, look, when we go to intubate patients, they have hypoxemia up to 40% of the time we go to intubate them. And the thought is that bag mask ventilation, or BMV, also bag valve mask would also work, may help prevent hypoxemia. The issue here that comes up is that a lot of us have been taught that, well, that's going to increase the potential that the patient aspirates. We're going to insufflate their stomach with air. They may aspirate during the intubation. And that's reflected in the guidelines. So there are various different guidelines that say, yep, you should bag the patient before you tube them, or because of this risk of aspiration, you should just pre-oxygenate and let things ride and not use the bag before you go to tube the patient. The clinical question here is, does using a bag mask ventilation during intubation result in higher O2 saturations and less severe hypoxemia? And this is a randomized controlled trial. It was multi-center. It's obviously unblinded. You can't hide a bag from someone. And patients were randomized into the bag mask ventilation versus no ventilation groups. Now, everybody had bag mask ventilation training prior to the study. And then in both groups, you were allowed to use pre-oxygenation or apneic oxygenation as you saw fit. Adults who were included in the study were adults who were being induced and undergoing a tracheal intubation. And patients were excluded if they were at a high risk of aspiration, and also if the clinician thought that they would likely need to be bagged between being induced and being intubated. So these are patients that they're looking at saying, I think you got a baseline kind of normal risk of aspiration, and I think there's a chance we could tube you without having to bag you.
You know, Matt, the clinical question here is, seems simple, but I do agree a little bit. I will pre-oxygenate or apneic oxygenate most all of my patients that I'm going to be intubating, unless I'm intubating them the minute they roll in. But I have done both. I've sometimes done the bag valve mask in after my medications are pushed until I actually take the look. And there are other times where I've just continued basically the apneic oxygenation. And so I am a little interested in seeing whether one of these is better than the other because, well, I have tried them both.
That's the wrinkle here, is do all the stuff we normally do, but does adding in the bagging the patient actually help them? They have several primary outcomes. We talked about the first one. The other primary outcome they look for is the lowest oxygen saturation level between being induced and 2 minutes after intubation. And then a secondary outcome is the incidence of severe hypoxemia, and they define this as an oxygen saturation level of less than 80%. So results, they enrolled 401 patients. That was 199 in the bag mask group. Out of that group, 100% of patients received supplemental oxygen because they're getting a bag. 201 patients in the no ventilation group. 77% of these patients had supplemental oxygen. Now, interestingly, they didn't prevent you from crossing over. So if you're in the no ventilation group and then you decide, I got to bag this patient, you are allowed to do that by the design of the study. And a fair number of patients who were in the no ventilation group actually got bagged. So 2.5% were bagged for hypoxemia, 21.8% were bagged for, quote, other indications. So almost a quarter of the patients who were in the no ventilation group actually got ventilations. All right, the primary outcome in terms of the median lowest oxygen saturation was statistically different between the two groups. So in the group that got the bag mask valve, the median lowest O2 sat was 96%. Compared to 93% in the no ventilation group. And again, that was statistically significant. Secondary outcomes, the incidence of severe hypoxemia in the bag mask valve group, only 10.9% of patients had SATs less than 80%. In the no ventilation group, 22.8% of patients had SATs less than 80%. That was statistically significant, and the number needed to treat in terms of Bagging people, how many people do we need to bag to prevent one case of low sats, was a number needed to treat of 9. So it's a pretty effective intervention in this patient population. Kind of discussion. So when they looked at these patients, these were pretty sick patients. So there were similar rates of death prior to discharge. So the saturations, the numbers were different between the groups, but about 35% of both groups died. Both groups had similarly low rates of aspiration. So the rate of aspiration was 2.5% in the bag group versus 4% in the no ventilation group. Now, this wasn't statistically significant. And the real rub here is that while this was a pretty big study, it wasn't large enough to actually look at the real risk of aspiration. So this gives us some evidence here to say, hey, in this study, these numbers were pretty much similar when it comes to the potential downsides, but it's not definitive enough to really emphatically say we know this for sure. And one of the big caveats was, would this actually apply to emergency department patients? These are ICU patients. They've probably been there for a while. They probably have a longer period of pre-oxygenation. They know more about the patients. Whereas you and I are getting people drug out of cars who aren't breathing well. We have no idea when they ate their last meal or drank their last bourbon. So it's a little bit different of a patient population, but still those primary outcomes are pretty compelling in terms of the benefits potentially from getting bag valve VASC for these patients. Bottom line here is that patients receiving bag mask ventilation between induction and laryngoscopy or intubation had higher oxygen saturations and lower rates of severe hypoxemia compared to those receiving no ventilations.
Matt, well, the real bottom line for me is in your clinical setting, which is the ED, are you going to change your practice in that period after you've pushed your paralytic and sedation meds and before you've put the ET tube in, or actually looked with the laryngoscope or whatever you've got? Are you going to do this bag valve mask ventilation, or are you going to continue just doing the apneic oxygenation that we've traditionally been doing?
I'm a little bit torn. I think this is a well-done study, and I think this study tells us very clearly that if we do the bag, we can expect that we'll have less severe hypoxemia, we'll have higher average oxygen saturations. Where I'm a little bit hung up is that the patient-oriented outcomes, so were more patients surviving if we did this. Those numbers were the same. 35% of both groups died. And so, I think we have to weigh this disease-oriented outcome. These numbers are better if we do this with this potential risk of aspiration that I think physiologically still seems like a risk. This study doesn't flesh that out completely. So for me, if I have a patient where I think, I'm looking at him, I think, you need to be bagged. My pre-oxygenation either isn't there, isn't working. This study equips me to say, I feel good about bagging you. I don't think I'm doing something bad. In fact, I may be helping you. But this doesn't push me to, on every single patient, to bag them between induction and intubation. I want to see ED-based studies looking at real patient-oriented outcomes before I make that leap.
Yeah, and you kind of speak to the reality of where we do work is we do this a lot, and that pre-oxygenation in a lot of our patients really holds the patient through, and we can get them intubated in a timely fashion without really them ever getting hypoxic. And so I agree with you. I'll probably just continue doing that. And then in my patients that are really sick and they're maybe starting off hypoxemic, like you said, they're going to need a bag valve mask. They're the ones, I'll continue doing that. So I'm not sure I'm going to change what I'm doing. And I'm wondering if this will ever go beyond, the ICU setting.
This is Hippo Education.